Good afternoon and welcome to the third session of our 14th Nuffield Trust Annual Summit. The summit gives us an opportunity to stand back and look at some of the big questions in health policy and to use our research and learning from others in seeking answers which can really help those people who are delivering health and care services to do that better. My name's Helen Buckingham and I'm the Director of Strategy here at the Trust, and I'm absolutely delighted to be chairing this session this afternoon, in which we'll be examining the question of whether integrated care policy can ever succeed. I'm going to be joined by my colleague Sarah Scobie and by Nick Mays and Mary Allison Duran from the London School of Hygiene and Tropical Medicine. Before we get into that, I really want to thank our sponsors, Optum, and our media partners, the BMJ, for everything that they've done to make these sessions possible. Please be thinking about the questions that you might want to ask our speakers. My colleague Rachel Hutchings will join us a little bit later on to put as many of the questions that you have as we can to our presenters, so you can post those on the platform. So let's get into this question about integration. And I'm going to start by reading you a quote from The Lancet. This week's white paper on the reorganisation of the NHS in England is welcome and wise. The picture is emerging and it looks none too bad. The call for integration has been heard for so long that some forceful utterance such as this was needed to save the plea from becoming a dim echo. Ever since 1948, the imperfections of the NHS have sprung mainly from three faults: lack of money, shortage of skilled staff in some areas, partly the result of fault number one, and too little enthusiasm amongst many of the service's members, enthusiasm to really make it work. The white paper, should it become the foundation of a new NHS structure, backed by ample resources, should revivify the whole scene. Some critics will regret the dearth of research and experimentation before action. Others will rightly point to the scarcity of able administrators. Others to the continuing separation of health and social services. And yet these will be in the minority. The future looks brighter. That wasn't published in recent weeks. That actually dates from 1972, 50 years ago. And since then, we've seen white paper after white paper setting out similar ambitions about ensuring joined up services, seamless care for patients, person-centred care and so forth. And very desirable objectives they are too. So why do they seem to be so difficult to deliver? The four nations of the UK have taken somewhat different approaches to organising health and care services over recent years. Late last year, my colleague Sarah Scobie led a team within the Nuffield Trust in looking at those different models, different approaches, and whether they actually delivered different and possibly some better outcomes for patients in terms of their approach to integration. So Sarah's going to be talking about the findings of that research in a moment or two. We'll then pass on to Nick Mays and Mary Allison Duran from the London School of Hygiene, who've been the lead evaluators on a number of integrated care pilots, approaches to integrated care in England. And they're going to describe their findings, and in particular some of the practical challenges that have faced people as they work to integrate health and social care. So without further ado from me, Sarah, over to you to hear more about the findings around the four nations.
Thanks very much. Thank you everyone who's joining the session today or is going to be watching later. So as Helen said, we have been working on a project to understand what's been happening with integration across the four nations of the UK. And in the next 10 minutes or so, I'm going to set out the rationale for the project and our approach, and the extent to which we were able to assess whether there's been an impact of integration. And I'll then talk through our analysis of the different policy levers that countries have used and the lessons that we can take as we go into the next phase of integrated care. But before I go any further, I just want to thank the team involved in this. So Sarah Reid, Camille Ong, Jenny Davis and Mark Dayan, who all made fantastic contributions to the analysis and itself. I think the first point to make, echoing Helen's comment, is that really there's been a very long history of integration. So since devolution in 1999, we found 68 major policy initiatives across the UK, 29 in England, 16 each in Wales and Northern Ireland and Scotland. So this is very much something that has been tried a number of times. And I think across these policies, there are quite a few consistent themes. So although the specifics and the terminology often may have changed for describing the initiatives, the aims have been around improving patient and service user experience and quality, improving efficiency by reducing fragmentation of services, improving population health and well-being, and reducing inequalities have all been common themes that have come through. And we hope that by looking across the 4 countries, we'd be able to find out a bit more about how each country had approached it and what the broader lessons might be. In terms of the context, though, the challenge for all the countries has been, and indeed health systems elsewhere around the world, has been around making the health system more fit for purpose for people with chronic and long-term conditions, and moving away from models of care that treat each illness as a separate episode in itself. So, how did we go about this? Well, I think the first thing that we observed is that there's actually, for something that's been around for 20 years or more, there's actually very little in the way of hard data and established, well-defined measures of integration and whether or not it's worked. What we did is, in that situation, is we went back to those 68 policies that I mentioned and undertook a thematic analysis to identify what the themes were, and from that we developed a long list of measures that related to the goals that the policies had set out. And with a long list of measures, we then went out in search of data, comparable data, ideally available across all the 4 countries and comparable over time as well. And this was a real challenge because in many cases there were differences in definitions between countries. There were differences in definitions over time, and there was generally a lot more data available about the acute sector actually, and much less about primary and community care, social care in particular. So it was a big challenge, but we ended up with 10 measures that covered 3 aspects, 3 domains of the policy aims. And I'm just going to talk you through an example of each one of those, just to give you a flavour of what we found. So we weren't able to find any measure of whether integration itself, whether individuals' experience of integration had changed. The closest that we found was in relation to satisfaction with social care. And there are surveys in each of the 4 countries. Now, the questions aren't exactly the same, but we can look at the trends in each country and see what's going on there. And what we found really is that there certainly isn't any evidence of improvement in social care user satisfaction, and if anything, it has gone down. So the second domain that we looked at was population health and inequalities, and we found a few different measures here. One of the things that we looked at is healthy life expectancy at age 65. So how many years someone has to live in good health when they get to that age. And we looked at the inequality, so the variation between how many years someone had in good health in the least deprived areas to the most deprived areas. And what we found that for women, this was pretty consistently about twice as many years in the most affluent areas, and that was the case as well in Wales and England for men, but in Scotland it was much higher, around 3 times as many years in the most affluent areas as the least. But what we didn't really see is any trend in this. We weren't finding that this was improving over time. So the third area that we looked at was measures of system efficiency. So the relative trends in spend for health and social care, length of stay in hospital, delayed transfers of care, and the chart we have here, which is emergency admissions. And this one is one of the few measures where there was really any discernible difference in the trend in each country. So Scotland has had relatively stable rates of emergency admission, whereas England and Wales, those have been going up. So in terms of our verdict, well, I think it's fair to say we were pretty disappointed actually by the time we'd got to the end of this phase of the project, because we weren't really seeing much in the way of patients benefiting in any kind of macro way from these integration policies. And we weren't really seeing any differences consistently across the countries either. And although undoubtedly there have been challenges with the data and the measures available, we developed those measures based on the policy goals. So I think there's a real question then about whether the policy goals and the ambitions are going to be delivered by what integration is actually doing in practice. So we looked next at the levers that countries had used, and we identified four levers that are shown here. So they fell into these broad themes, and there are some examples there as well. And I think there's a couple of sort of general observations about this. One is that it's worth noting that at the national level, there's been a real reliance on structural and organisational levers, and very little about what this looks like in practice at a clinical or a care pathway level. And I think the second is that while we found some differences between countries, these were very much more in the degree to which these levers have been applied, rather than one country having done something unique that hadn't been used elsewhere. And there were it was very clear that there were sort of more similarities than there were differences. So there's a few examples here of different aspects of the levers which policymakers have used. There have been various ways in which statutory organisations and partnerships and authorities have been used to make integration happen. There have been financial incentives, such as pooled budgets, that have been tried in different ways in each country. And then in some countries, they've also used coterminous boundaries between health and social care bodies, for example, to help see if integration can be made more effective. So what are our sort of overall lessons here? Well, I think there's a general theme that, as we said, although there's been a lot written and said about differences, actually in practice, organisations have relied on the same kind of levers and ended up with the same kind of results. And I think it was clear to us that there's been really an over-reliance on structural and organisational levers to drive integration, and that these are not enough on their own. So in the future, policies are going to really need to be realistic about whether the changes that they're seeking are going to come about through the methods which they're attempting to use. Again, with the use of legal duties, having a legal duty to collaborate doesn't necessarily mean it's going to happen in practice. there's clearly a lot of other things that need to be considered. So the culture of the different organisations and the different groups of staff involved. So how pay and professional training and expectations vary between groups of staff and between different organisations is an example there. In terms of finance, we really found limited evidence that integrating finances have led to cost savings or more efficiency. What we did observe, though, is that often initiatives that start off identifying integration as a good thing in itself and good for patients do over time tend to end up being focused on quite narrow financial measures. So the target around reducing emergency admissions, for example, has been used for a number of programs and initiatives in order to reduce acute care costs. So I think sometimes the focus on finance can actually move away from what might some of the benefits be of integration for individuals. And I think our final point here as well is around performance management. So performance management has tended to focus on organisational performance, particularly in England. You know, a strong focus on delivery, say, of acute trusts, and there hasn't been the same counterbalancing measures or targets or effective ways to track how integration is working across the system. That's something that it would also be good to see if there could be some developments in that area. But I think our overall conclusions really is that policies that have been there have just not been have been overambitious, and for the future set of policies, then we really need to think about whether they're realistic and going to achieve the aims that they set out.
Thanks, Sarah. So looking from the top down, it's not clear that different policy approaches to integration have actually driven any better outcomes looking across the 4 countries of the UK. So we'll turn now to Nick and Mary Allison, who obviously have been looking at integrated care on the ground, and see what lessons that we can get from the bottom up, if you like. I think, Nick, you're starting off, aren't you?
Yes, thanks very much. We're going to be doing 2 things. It's going to be a 2-part presentation. I'm going to take a sort of an overview of the evaluations of various of the initiatives. They haven't all been evaluated in England, but there has been quite a lot of research activity over the last decade. And Mary Allison's going to use the work that we've been doing over the long term, the last 5 or 6 years, looking at the Pioneer programme and following the Pioneer sites well beyond the end of the formal programme. In order to really look at more at the micro level, is to say, well, what does health and social care integration actually look like day to day actually currently, because most of the data we're still analysing at the micro level. So I just want to kick off by, sort of reminding us that this has been a very turbulent environment in England. And I'd slightly differ maybe from Sarah in saying that a number of these initiatives, although they might have had an organisational and administrative component, were also designed to try and change the way that care was delivered on the ground. So the integrated care pilots and the pioneers that we started studying way back in 2014, and indeed the Vanguard programme, even in its title, New Models of Care, they were trying to sort of simultaneously work at the 4 levels of integration that Sarah put into a very nice paper recently, sort of organisational, administrative, service and clinical. And I want to just look at the evaluations of some of those major programs. With colleagues, we put together a paper recently in the International Journal of Integrated Care, putting together and summarising and trying to draw out some of the implications for current policy of the main evaluations since the Integrated Care pilot programme over 10 years ago. So here's a very brief summary of what we said in that paper in terms of the common findings across the different programmes and over time. The obvious point is that many of these things are reasonably well known, and one of the questions I want to leave us with at the end is the extent to which the current Health and Care Bill and the February Health and Social Care Integration White Paper add anything to the mix of policy approaches, levers, targets, and focus that would move us beyond what we already know. So these studies tend to show that leadership is really, really important, that it's facilitated when those leaders have a longish local track record of trusting relationships. All the studies demonstrate the importance, certainly for that kind of clinical and patient level, of being able to share data between organizations, particularly between health and social services, and that this is difficult and time consuming. Incidentally, the Pioneer program in 2013 was promised help and support to enable integration. And it's clear that even now, many of those sites still struggle with that data integration. Time is always regarded as important, and each of those programs, the evaluations have generally reported that there wasn't enough time to make progress, although since those programs build on one another, there's a question remaining as to how much time do we need. As Sarah was saying, the impact on patient experience is generally modest when it's been measured within evaluations, and certainly it's not measured routinely outside of research studies. I think an interesting point, most of these studies show that staff generally value and appreciate working in more integrated environments. When you get to more ambitious contractual and budget pool type arrangements, particularly actually the Vanguard program, which was probably the most ambitious of the recent schemes, really struggled to achieve contractual integration of commissioning and provision of services based on budget pooling. I think despite the fact, as I said earlier, that many of these programs did try and look at the kind of clinical and service delivery level, as well as perhaps the organizational level, when you boil down what they were actually doing in practice at the kind of patient level, often the pilot schemes, even if they came from slightly different vantage points, ended up sort of defaulting to a small number of activities. So forms of multidisciplinary team case management, forms of care coordination, which obviously relate to MDTs, and Mary Allison's going to talk about some of that in a bit more detail, social prescribing, and a variety of kind of fairly well-known schemes, risk assessing patients that are likely to end up in hospital and trying to avoid admission. And I suppose arguably you might say those are mechanisms for integrating, but they aren't necessarily demonstrations of integrated care itself. So what we concluded from our very rapid overview was that perhaps in the future, when we're thinking about developing integrated care and mounting initiatives, we should focus more on the kind of supports and processes and infrastructure and training and skill development and particularly common training that needed to support the work of integration, rather than trying to identify a set of models of integrated care that might work better than other models. So there does seem to be, I think, a bit of a tendency to try and find a holy grail and say, for these kinds of patients, what's the best model? What's the best pathway that we should be using? So that was our conclusion and overview from a very sort of high-level review of quite a large body of evaluative research. And Mary Allison is now going to dive down into the day-to-day detail of the most commonly identified activity that we saw in the Pioneer program on the ground, which was community-based MDTs. So over to Mary Allison.
Thanks, Nick. So as Nick says, I'm going to present some emerging findings from our evaluation of community-based health and social care integrated MDTs. And we conducted a multi-methods evaluation of MDTs, 11 MDTs in 2 pioneers. And the findings that I'm going to present now are from our observations of MDT meetings and also from the ongoing analysis of interviews with strategic level and frontline staff. Next slide, please, Nick. So first of all, to just look at the purpose of the perceived purpose of MDTs. So the rationale for implementing MDTs was said to be to reduce pressure on NHS resource through integration of various services and sectors, particularly primary care, acute sector and community services, with input from adult social care and voluntary sector services where available. And the aims of MDTs were said to be to provide patient-centred, joined-up care or coordination of care to enable people to live independently in their own homes and in the community for as long as was possible or appropriate, to prevent hospital admissions and readmissions, and to facilitate discharge and post-discharge care. The factors that were said to facilitate the development and implementation of MDTs included having a local history of integrated working and good working relationships between different organisations and services, with an existing ethos of patient-centred care. Strong local leadership was also said to be vital, including having a vision for the MDTs and integrated care generally, and also perseverance. So perseverance in terms of having to bring together a range of services, organisations and professionals on board, for example, general practitioners. Funding and resources were also seen as vital facilitators, as well as sensitivity to local needs and also to local stakeholders' priorities and opinions. Next slide, please. While there were commonalities across the two pioneers in terms of the facilitating factors for developing and implementing the MDTs themselves took different forms and different operating models were implemented. So in Pioneer 1, there were 8 MDTs operating to the same model, while in Pioneer 2, there were 3 MDTs which operated to different models. And they differed in terms of how they were organised, whether they were organised around general practice or a group of general practices, or operating out of acute trusts, in terms of the administrative support that they received, and also in terms of the frequency of meetings and who was chairing the meetings. How they were constituted also varies, though the concept of a core team and extended networks was common. And so the core team was said to consist of those professional services and organisations that were represented at the meeting. So, for example, general practitioners, community and district nursing, mental health, social care, representatives of community and voluntary sector organisations, were frequent attenders or regular attenders and part of the core team in the sites. However, the kind of extended network were the teams that sat behind those who were attending the meeting. So, for example, adult social care or mental health, for instance, and also the services and organisations that patients could be referred to, for example, specialist services such as drugs and alcohol services. The makeup of the team as well tended to be associated with local priorities and needs. So, for example, where in those MDTs where frail elderly people were the focus of the caseload and priority, OTs and physios and care workers, healthcare workers were also part of the core team. Next slide, please, Nick. Okay. Just to look briefly at the perceived benefits to patients and staff, and the added value of working in an MDT format. So staff perceive there to be more joined up and less siloed working, and more flexibility in terms of professional roles and responsibilities. They reported having increased knowledge and understanding of local services and of one another's professional roles and capacities. And this was said to lead to improved access to services and to other professionals, with less bureaucracy around it. When people are sitting around the table, it's easy to talk to one another. The meetings allowed for real-time information sharing and decision-making, and also as a group, being able to find creative solutions to what could sometimes be very complex patient problems. And we saw that in operation when we observed the meetings. Staff also said that they had increased job satisfaction through working together, and we're pleased to have the opportunity to share the burden of care for what, as I said, could sometimes be very complex cases. In terms of potential for patient benefit, it was perceived that there was the patients could receive an increasingly holistic care from a range of services that they might not traditionally have received care from. Next slide, Nick, please. So just to finish with some of the barriers and challenges to this way of working. And a number of barriers and challenges are emerging in our data, but some of them are around operational procedures and operations generally. For example, in relation to the professionals and the services involved. So for example, one of the challenges is around team composition. Who's absent from the team? What services are needed, if you like. So, for example, housing was said to be something that was very much needed at some of the MDT meetings, but wasn't present. And sometimes it was seen as difficult to engage GPs or other professionals. In terms of staff turnover and availability was also seen as a challenge, particularly where senior members of the team left, as they were seen as providing direction and consistency within the team and stability. Long-term funding for posts is always a problem. And local capacity and resource availability was also seen as a challenge. So you might want to refer a patient to a number of different organizations, or services, but they might not, for example, have coterminous boundaries. And geographical issues also made things difficult. In terms of another operational issue or challenge, that was around IT and shared records, and the absence of shared records, plus different organizations, different services using different non-compatible systems. And we saw people having to do workarounds, sitting around a table with their laptops, each looking at their own records. I think another challenge to this way of working is defining and measuring success, as we've heard already. And while admissions prevention may be seen as a key indicator at population level, when you're working in an MDT as a frontline member of staff, it can be very difficult to say, well, we've prevented X number of admissions, or even where hospital admissions may decrease locally, it can be very hard to ascribe those solely to the MDT when there are lots of other things happening in the area. And sometimes staff see admission as the correct path for a patient anyway. In terms of other measures of success, staff indicated that things like organizations working better together, the ability to provide more holistic care for patients, etc., could be seen as measures of success, but obviously less hard to define and less hard to measure objectively. I think just to finish, and as Nick has said already, the findings from our kind of deep dive and detailed look at frontline staff is that integrating care is not something that happens overnight. It takes a lot of work and a lot of time to get it up and running, or at least the mechanisms up and running and care started. Okay, thanks, Nick.
Thanks, Mary Allison. I'm just going to make a very few remarks at the end because I'm aware of time. Mary Allison mentioned time, and in case we get too pessimistic about progress and about what health and social care integration might actually mean on the ground, I'll just put on that slide the results of our annual surveys of key informants in the pioneer settings, and you'll see, or you may not see, but I can assure you that the most important sort of barriers and obstacles to health and social care integration at what you would call place level, using the jargon of the Health and Care Bill, have gradually been reducing over time. So it's fair to say that with these successive waves of different kinds of pilots and initiatives, there does appear to be modest progress over time in dealing with some of the practicalities. But as Mary Allison has said, there are still many issues on the ground when you're trying to work in an interdisciplinary or multidisciplinary way. So I guess what I thought, rather than going into great detail about the policy implications of the current legislation and the white paper, but was to sort of throw open to the floor and to the panel a question really. I mean, given the progress that has been made, it has been quite modest, and given the defaulting of integration to a certain small range of activities on the ground, what is there in the bill and or the white paper that would be a game changer, that would be qualitatively different from what we've seen up to now? And if there are mechanisms and things in those in the legislation and the white paper, how do we make sure that those mechanisms actually work as predicted? So, for example, in the white paper, I think it does correctly focus on barriers to integration that are kind of well known from previous studies, such as the importance of leadership, the kind of digital sharing of information, and certainly highlights the focus on workforce and skills and so on. But those things are pretty well known. So the question really is, what's different, and what are the odds from an English perspective that this particular round of legislation and policy development will be a game breaker? Thanks.
Thank you both. So I think from Sarah's presentation and from Nick and Mary Allison, what we've seen is that policy levers can really only take us so far, that actually there's some real challenges on the ground that need to be addressed. Please keep thinking about your questions and posting them. But before we open it up to questions from the floor, as it were, the electronic floor, we thought we'd get some responses from people in different parts of the system, have some different perspectives on these experiences. And we're going to start with Sarah Pickup. So Sarah, you've had many years of experience in local government, delivering integration from that end of the system rather than from the healthcare end of the system. Do you want to give us some reflections on what you've heard today?
Thanks very much. Can you hear me okay?
We can. You
can, okay, just because I'm on my phone and I'm a bit anxious about it. Okay, so they are really interesting presentations, and clearly integration is not on its own a solution to delivering good care for people or improving their lives, and nor is it a short-term quick fix. So until we've got embedded ways of working, it's quite hard to see. And once they are embedded, it's in a sense quite difficult, because that's the way you work now. But just a few points from me would include that we definitely mustn't see integration as a way of saving money. It should be about doing things better. And the other thing is that we don't know what the counterfactual would be. So, you know, if we haven't reduced admissions, well, might they otherwise have gone up? So at the moment, there are more people delayed in hospitals, but equally, councils are also commissioning more home care. So you can't say that because things haven't improved, they would have been better or the same if you hadn't integrated. So that's the first thing. The second thing is we have to move away from just thinking about hospital admissions and discharges and those sorts of things, because this is about keeping people healthy and well. And what we also have to remember is that it's not just about getting together and doing the same things as we did before, doing the same things together. It's actually about changing what you do, more prevention, more early intervention, identify different solutions. And also putting two leaky buckets together doesn't magic up resources. So, you can have a really integrated system that identifies someone would really benefit from physiotherapy, but if you have no physiotherapists, then maybe they deteriorate just as they would have without the integrated system. I think that some of the things that have been looked at in the presentation, so life expectancy obviously is a very long outcome in terms of differentials in different areas, and reduced hospital admission is very specific. But I think we need to think about, first of all, we need to think about different things at a different level of granularity, because averages can mask benefit. In addition, when we're thinking about is it successful, we need to think about how it feels for people is important. So the slides about how staff felt and how there was potential for outcomes for people were good, but also how quickly they recover, how quickly they're diagnosed. Do they have access to treatment? Do they have less escalation of their condition? And these things are much harder to measure. And I think, I don't want to be, I think we shouldn't be disheartened by the fact that it's hard to measure the benefit that you get. I think we should embed and seek to talk to people. We should look to some of the things that have been around for a long time, like some of the community mental health teams that have worked and are successful really can show how integration works, and that can apply sometimes in learning disability as well. I hope those few comments are helpful.
I've just been reminded I was on mute. That was very careless of me. So, Stein again. David, you're looking in from Scotland. Now, we've heard from Sarah, Sarah Scobie, that maybe the outcomes are not so different in Scotland. But how does it feel? What resonates with you from today?
Not just the outcomes, Helen, but also the analysis. We've had two great presentations on reporting on important studies. And I agree with almost all their conclusions, and indeed with the comments that Sarah has just made. But despite Nick's slightly more optimistic tone at the end of his presentation, they leave me feeling very depressed about the answer to the question posed for this session: can integration policy ever succeed? But wait a minute, because I think there is a solution. As a number of you have said, the last 30 or 40 years have been characterized by overselling and under-delivery of multiple integration initiatives. And it's striking that both the studies that we've heard about this afternoon use the same adjective to describe the impact that's been received, and that is modest. And in fact, if you look in more detail, I've had the benefit of seeing Sarah's report. It really is very, the progress made, except in one or two areas, has been very limited. Now, why is this so? I believe very strongly that we need to search deeper for the explanation. I welcome the fact that both these studies have searched for underlying causes of the lack of progress, because many such studies haven't done that. Nick's last slide referred to the need for a game changer. Sarah's report concluded that without significant changes to the broader context and addressing the culture, norms and systems, we weren't going to succeed in making significant progress. All this is spot on. And I would go even further. The game changer for me is the very unhelpful political climate and context in which integration has been and continues to be pursued. Debates about healthcare continue to be dominated by the acute sector, acute and waiting lists and so on. And NHS and NHS staff are rated much more highly than social care by politicians, the media and the public. In this climate, integration initiatives have been flowing against a very strong tide until, in my view, we reach a point where we're closer to integration of equals, whether you're talking about health and social care or acute and physical and mental health or secondary and primary care. All these initiatives, and I include the most recent ones in Scotland and in England, will achieve, in my view, only differing degrees of marginal impact. I say differing degrees because evaluative and comparative studies can, of course, help us learn from experience and fine-tune what we're doing. And both studies we've had this afternoon show that we have made progress in some respects, but progress will continue to be slow and at best incremental. We will be stuck, to change the analogy, with pushing a very large boulder up a very steep hill, unless we address and change the wider context in which integration is being pursued. That's not easy, I know, but it's essential in my view, and it's certainly not a reason for giving up because of all the benefits that integration can produce. And it's something which we can do at the same time as pursuing and responding to the analysis that these studies have generated. So that's my main point. Can I just make one other quick comment? This is a Scottish perspective. I particularly welcome the full-blown four-country focus of the recent Nuffield Trust report. One of my great disappointments in the last 20 years is how little use has been made of the field laboratory created by devolution. we would all benefit from much more of this sort of work. And to that end, I think it's important that we think about how we build capacity in the 3 devolved countries in order that they can contribute effectively to such studies. Sorry, Helen, if I've gone over time, but both these points are ones I wanted to get across. Thank you.
Thank you, David. No, really helpful. And we were hoping to have a third contribution from Fear Stein, who's the Chief Executive of Leeds Community Trust. Thea had some technical problems joining, but she sent us the comments that were coming to her as she was listening. So I'm just going to run through those very briefly. And she had 3 points to make. Policy of any type only gets you so far. And I would absolutely echo what Thea's saying here. She's seen great integration happen despite policy, and the integration fall apart without policy in place. People, power and personality are always key in Thea's view. And they can either get in the way or they can make things happen. They're often at the root of why things are or aren't replicated. Policy can get in the way of good people trying to do the right thing. And so not well thought out policy can get in the way, where actually the example Thea is giving here is the policy of such PCNs, primary care networks, which we'll talk about perhaps in our session tomorrow. PCNs are great in many ways, but because employment practice is often outside the NHS, that can disrupt integration if it's not properly thought through. And Thea's final point is that policy often focuses on the big overall strategic statements. It's about bringing social care and health together, or it's about integrating a pathway. But actually, it's the nitty-gritty of terms and conditions, the basic things that affect people's day-to-day working lives, recruitment practices and so on. They are the things that either can get in the way or they can drive better integration. So those are the 3 points from Thea. Now we're going to open up to questions from the floor. I'm just going to touch on the question that Nick left us at the end of his presentation as Rachel comes into us with the questions from the floor. David's touched on it already, but what are the game changers? From my perspective, I'm not entirely convinced there is a game changer within the bill or the white paper. I think the game changer for me, and this goes very much, I think, to what both David and Thea have said, is in the leaders that I see in systems now. And I've worked in health and care this is my 30th year, so I've seen quite a few different iterations of what a good leader looks like, and it's very situational. And what I see now are leaders who really understand that their role is to lead an organisation within a system. So then it's not about the organisation being supreme, it's that the organisation is an important part of a wider system, and that is their leadership challenge. And that is complex, but I'm seeing more leaders who are able to do that and able to work with their teams to encourage that. So the game changer for me is not what the legislation says. The legislation can help, but the thing which will actually make a difference is the ability of local leaders within the health system, within the social care system, and across the wider system, and to David's point, including politicians, who are able to create the cultures that will enable integration to flourish. So Rachel, what questions do we have from the floor for our panel?
Hi, Helen. Hope you can hear me okay. We've had some really interesting questions coming through, so thank you everybody for sending those in. I'm just going to come first to a question from Stephen Black, who says, integration is a mechanism, not a patient-related goal. And presumably the goal is better coordination of care for patients. So is there any evidence that it works to achieve coordination? And is there any evidence that organisational structure is actually the cause of poor coordination?
Nick, Mary Allison, do you want to pick that one up from your evaluation work? Nick, perhaps?
I mean, we tried valiantly to try and look at patient experience. We're actually analysing some data at the moment, because the Pioneer programme, when it began, was very much focused on improving that experience. The difficulty of providing evidence that would convince people that sort of it's better than disintegration is that throughout that period, when I put up that first slide, that long list of initiatives, it isn't as if anyone in the UK has been trying to provide uncoordinated care. So whenever an initiative comes along, I mean, the challenge for evaluation is what's the comparison, and that certainly has been one of the issues that we faced in our study, which we did try and go beyond some of the previous studies. We did try and look at patient experience and carer experience as well as the conventional measures. We also wanted to look at quality of life and so on, and to try and compare, places that were doing things through the Pioneer program that seemed innovative. And then we discovered that the most prevailing activity was what Mary Allison's just been talking about. And when we went to our comparison areas that were non-pioneers or were not, and they said, well, we're doing that as well. And so in a way, the comparison is very, very difficult to establish from a sort of researcher's point of view. So I think it's very hard to answer the question. I mean, I do agree with the sentiment that sort of integration in its many definitions is only a mechanism. And other people have said things like, well, users and carers shouldn't actually know that we're trying to integrate care. They should just have an experience of being, of engaging in a care system that seems to work for them. I mean, I think it would help perhaps if we did more routinely try and capture, I'll call them users and carers experiences, but it's laborious and it's expensive. It's much easier, we've got a hospital admission system. We can collect those data relatively straightforwardly. We do, and so of course it ends up with researchers using the data that's available, because trying to get new data is really hard work, as I've just explained.
So that goes to the point that Sarah was making about actually really making sure that we measure the right things. Should we move to the next question, Rachel?
Yeah, thanks, Helen. So we've had a couple of questions sort of around the theme of governance. So I'm just going to try and kind of combine them. So we've had a question from David O'Hagan, who acknowledges, I think, something that's come through on the discussion, which is that this is a goal that's been sort of pursued for a long time. It's obviously a work in progress. But the question is, or the question for today that David says is, which model of governance is the next reorganisation going to establish, and will that be effective in reducing the criticisms around the last reorganisation? And I think sort of similarly, we've had a question and a comment from Billy Palmer at the Nuffield Trust, who notes that integration care initiatives in England are rarely underpinned by governance arrangements that actually are essential for success. And without this, they're doomed to fail. And is that a reasonable comment?
Sarah, when you did the 4 countries work, you looked at different governance models in the different countries. Do you have any thoughts on those questions?
I mean, I think that what we found was that the governance models that had been tried weren't necessarily the answer. So they may have helped in some ways, but they didn't bring about integration on their own. And I think one of the challenges is that a lot of the governance models were applying additional governance on top of the governance that already existed. So so social care organisations reported through local government, and there were counsellors and other lines of accountability. The NHS, in different guises, already has other lines of accountability. So the integration and governance was added on top of all of that, and we didn't really find evidence that what had been tried so far, that any of those models are going to be successful on their own. It's very much a question of in a way, the focus on those perhaps leaves a lot of things that haven't been addressed. So the culture and the relationships that are needed to make integration happen in practice on the ground, or for effective close working between teams and organisations.
And to Billy's point about the alignment of funds, I mean, we know that one of the things that we thought might come in the integration white paper was perhaps not quite as stark as we'd expected, which was a push towards pooled budgets. Now, the integration white paper is saying that they're going to look at the legislation and see if it make it easier to pool budgets. But from the work that you did on looking at the 4 countries, how significant a difference do you think that will make?
Well, I think there hasn't been clear evidence that pooled budgets have made a big difference. There have been examples for particular types of activity, but they haven't across the board, been a significant game changer. And there's partly questions about how much of the budget is pooled, for example, and also the challenges that it can bring about by ring fencing some aspects of spend and not other aspects that can introduce, other challenges.
So it's an obvious tool to look at, but not something that will fix a problem by magic, as it were. Yeah. Rachel, next question.
Yeah, so we've had a question from Megan Kenyon, who's talked about, we've mentioned the importance of local leadership, and says that in the white paper we've heard of the government's plans to introduce a single accountable figure to lead integrated care place boards. What benefit, if any, will these add, or will they just add another layer of complexity?
I think I might start on that one and then perhaps ask Nick and Mary Allison for their perspective. I mean, for those who've read the white paper, there's a fairly horrible looking diagram in the middle of it, which shows this single accountable person in the middle of the place, surrounded by the various different systems to which he or she is accountable, or for which he's accountable. So all the providers underneath, the two local, different local authorities, the accountability system of the NHS, the accountability system for local authorities. So it seems to me that if you're looking down, to have one person that you can look down to and say, this person is accountable for sorting all that out, simplifies things, but it doesn't necessarily make the life of that person very simple. And that's, so actually, if things are working well and local organisations and local leaders are working well together, then actually that person has a very powerful role in convening and actually, enabling some of the nitty-gritty to be addressed. If relationships are perhaps not where they should be, if there are significant challenges in those local systems, then the risk is that person is pulled apart by the different accountability systems to which they are responsible. So I'm not sure that it's the panacea for everything. But Nick, briefly, do you have any views on that question?
Just really shooting from the hip type views. I mean, it seems that there's I absolutely agree with you. That diagram in the white paper scared me quite a lot. I would like to have to explain it to someone who's not intimately familiar with the English health and care system. And even a public policy student from another country, if you try to explain what that all meant, I think you'd be struggling. So I wondered. I think the other thing is about, does it actually let the leaders of the other organisations in the local system off the hook? Because one of the things about well-functioning systems, I thought, was that they function inevitably on distributed leadership, and that we all have to feel that it's our responsibility. But if once again we've got a sort of local figurehead, well, it's their responsibility. So maybe there's something that needs to be thought through there in terms of actually how organisations do work together, and who's that person that becomes their identity. Then, of course, becomes very, very significant in the local system.
Back to Thea's point then about people and personalities. So we are fast running out of time. So I think just to wrap up very briefly, I think what we've heard from all our speakers is that structural and legal solutions don't in themselves lead to better integration. They can help or they can get in the way. But actually what does lead to better integration are the points that both Nick and Sarah and Thea were making about really doing the work on the ground. What's the work that's needed to achieve better coordination, better outcomes for patients in this place, and how do we make sure that we've got the right measures for it? Policymakers and practitioners absolutely do have the same aims. It's about achieving better outcomes for the people who use services. But the big policy levers are not necessarily the things that are actually going to achieve that on the ground. I want to thank all our speakers today, both Sarah and Mary Allison and Nick with the presentations, and Thea and Sarah and David with their responses. To thank you, the audience, for your questions and for listening. Everybody in the Nuffield Trust and StreamGo who've made the worked behind the scenes to make this work, and also again just to thank our partners Optima and the BMJ. And finally, to remind you of two things: that you will get an evaluation popping up, so please do your evaluation, and that our next session tomorrow morning is looking at sustainability in general practice. So we look forward to seeing as many of you as possibly can there. Thank you.